Welcome to Nursing with Professor B. In today's video, I will be going over an ACLS cheat sheet. You will pass your ACLS if you review this carefully. Make sure that you stay until the end because I will be going over ACLS medical emergencies. I will be covering which rhythms are shockable as well as what you are supposed to do for example, SVT, which drugs are you pushing, etc., etc. This is if you are taking the ACLS class with the American Heart Association. My name is Bridget. I have a master's degree in nursing education, and I went back to graduate school in order to become a family nurse practitioner. I am board certified. I'm going to start with a comprehensive review, and as we go on, we'll focus more on the ACLS portion of it. Initially, it's going to be the BLS review too. But you always want to do compression, airway, breathing. So they changed the recommendation from ABCs a while back to CAB, which is compression, airway, and breathing. Compression first being the key there. You want to recognize an unresponsive patient. You check for responsiveness. If no response, you proceed with the assessment. You activate 911. You get the AED. If help is around, request their assistance to activate 911 emergency system and get the AED. You're going to check for a pulse. This should take at least 5 seconds, but no more than 10 seconds. You should check for breathing during this time. This is a test question, like your pulse check should take no more than 10 seconds. That has been a question on there. You want to check to see if they are breathing, or not breathing normally. And agonal gasping is not considered a breath. That has also been on the exam, and this is not considered breathing. CPR sequence. You want to start CPR beginning with chest compressions. They always ask about the compression rate. You want to do at least 100 to 120 compressions a minute with hand placement at the mid nipple line / lower half of the breastbone. Compression depth should be at least 2 inches, but not more than 2.4 inches. They love to ask about the compression depth as well. This is another frequently tested question. They ask about chest recoil. You want to allow for full chest recoil between compressions. You don't want to just think of if you're squeezing something and you're not letting it pump, right? It's only if you're squeezing it, if you're compressing, you're making the heartbeat too fast, so that whatever little blood is in there, it's barely squirting anything out. So you want more to be pressed out. In order for more to be pressed out, you have to allow the full chest to recoil. So this will allow for the heart to adequately refill between each compression. Compression interruptions. You want to minimize interruptions in chest compressions. It is recommended that interruptions be limited to less than 10 seconds and rotate the person providing compressions every 2 minutes. If no trauma is suspected, you're going to utilize the head tilt chin lift. If suspected trauma, if no trauma, you're going to utilize the head tilt chin lift. If you suspect trauma, you utilize the jaw thrust maneuver where you don't move the spine if there's trauma so that you don't risk injury, and you just thrust the jaw forward while the spine stays in the same direction. The compression to ventilation ratio is 30:2. So for every 30 compressions, you're doing 2 breaths during single rescuer or multiple rescuer CPR, and this is for adults. Ventilations with advanced airway. When an advanced airway is placed, you ventilate the patient 1 time every 6 seconds for a total of 10 per minute. You always want to look for visible rise of the chest to confirm adequate ventilations. Defibrillation. Once an AED defibrillator is available, use it immediately. Immediately upon defibrillation, start CPR beginning with chest compressions. You immediately start. You don't wait. You don't just start right away after you defibrillate. That actually rhymes. Start right away after you defibrillate. I just made that up right there. Basic life support for healthcare providers. High quality CPR will increase the chance of victim survival. You want to start compressions immediately after confirmation that a patient has no pulse. So always no pulse, boom, 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 we're starting. This should take a minimum of 5 seconds, but no more than 10 seconds to confirm. There it is again. I'm telling you that is usually tested on, no more than 10 seconds. Compress at a rate of 100 to 120 per minute for all patients. That's usually tested on too. The depth is tested on. Push to a depth of 2 inches and a maximum of 2.4. Allow for full chest recoil. Provide breaths until you see visible rise of the chest in all patients, and you want to avoid excessive ventilations as this can lead to decreased blood flow. Okay, so with an AED, which stands for Automated External Defibrillator, you want to turn it on. Very important. Turn the AED on. You follow the prompts. Honestly, they make these AEDs very idiot-proof. When the AED becomes available, you use it. This is the only time that stopping CPR is appropriate, mid 2-minute cycle. After this point, you will use the AED on the 2-minute pause/pulse check. If the AED analyzes and determines the victim requires defibrillation, do so only after clearing all bystanders and healthcare providers from the victim. So we look around, we say, I'm clear, you're clear, we're all clear, and then the shock will be delivered. Immediately upon defibrillation, resume CPR beginning with chest compressions. Adult pads should be used on adult patients. The AED can be used for a patient lying in snow. Clear the victim's chest. The AED can be used on a victim submerged in water. First, remove the victim from the water and wipe the victim's chest. A while back, the rules have changed a little bit with snow and water. AED can experience difficulty if the victim's chest is hairy. When possible, the victim's chest should be shaved with a medical razor or pads firmly placed to ensure chest contact. And there are razors in the AED for you to do this. Foreign body airway obstruction choking victims. In a responsive choking adult, perform abdominal thrusts until the item is dislodged. If the patient becomes unresponsive, assist the victim to the floor, carefully supporting their head. Activate the emergency response system and start CPR beginning with chest compressions. So you're going to do the Heimlich essentially until they pass out. And once they pass out, then you're going to start CPR. For chest compressions, we're telling you the same thing over and over again. You always want to make sure the scene is safe, number one, before you approach a client. And you're going to remember that typical, you tap them on the shoulder, hello, hello, can you hear me? If the victim has no pulse and is not breathing, CPR is required. Again, in order for you to do CPR, they have to have no pulse. If you feel a pulse, no. When assessing a pulse, no longer than 10 seconds. Palpate a pulse on the adults on the carotid artery, either side, right? You never want to palpate both sides because you're shutting off the circulation. And essentially you're making the situation worse, right? So always when you check, even when you're a nurse or whatever, you're always assessing one carotid artery at a time. Right here I can feel mine, so I'm going to go over on this side and I can feel my pulse. Palpate a pulse on infants at the brachial artery, underside of the bicep. So in infants, you're going to palpate the brachial artery. Blood flow is needed to perfuse the patient's brain and vital arteries. This is successful when we compress to a depth of 2 inches on adults. All patients should receive 100 to 120 compressions per minute. Remember to the song of staying alive, staying alive, staying alive. Like that's how much you should be compressing. The rescuers providing chest compression should alternate every 2 minutes. When one rescuer is providing chest compressions, the other rescuer should be providing breaths. When performing chest compressions on an infant single rescuer, the 2-finger technique should be utilized. When performing chest compressions on an infant 2 rescuer, the thumb encircling hands technique should be utilized. Compressions adult 30 compressions to 2 breaths. What you need to do with Airway. If the patient has no suspected neck injury, you do the head tilt chin maneuver. If the patient has a suspected neck injury, the jaw thrust maneuver. I can't really do it myself, but you don't want to move you just thrust the jaw open. You don't want to move the spine. When I used to work as a lifeguard, we would just do the jaw thrust maneuver because we didn't want to risk with the head tilt chin lift. To provide adequate breaths, the rescuer should make best seal to the patient's nose and mouth when providing breaths. If no method for safely providing breaths is available, such as a bag mask device or a pocket mask, then hands-only CPR should be used at a rate of 100 to 120 compressions per minute. That's interesting, right? So if you don't have some kind of shield, you're only supposed to do CPR with your hands. Suctioning of a patient should be limited to less than 10 seconds. And an oropharyngeal airway should be measured from the corner of the mouth to the angle of the mandible to ensure adequately sized placement. Breathing. We've gone over visible rise of the chest as a key indicator that breaths are effective. Do not provide excessive ventilations. It can cause gastric inflation. I do remember that being part of a question, something about that. With an advanced airway in place, compressions are constant with no pauses, and ventilations are provided once every 6 seconds for all patients. Continuous waveform capnography is the preferred method for monitoring the placement of an endotracheal tube. That is a test question, okay? So continuous waveform capnography is the preferred method for monitoring the placement of an endotracheal tube, not checking the acidity or the pH of it, not other methods. So the PET CO2 should maintain above a reading of 10 during CPR. If the numerical reading decreases below 10, then it is assumed that chest compressions are not adequate. Cardiac arrest team dynamic approach. The structure or universal approach to the cardiac arrest emergency does not change regardless of profession or setting. CPR should take place in 2-minute increments, allowing for approximately 5 cycles of 30 compressions to 2 ventilations. Upon completion of a 2-minute CPR cycle, a pulse should be palpated for at least 5 but no more than 10 seconds. So after doing CPR for 2 minutes, you check a pulse for at least 5 to no more than 10 seconds. If you feel a pulse, then post-cardiac care should be initiated. If you don't feel a pulse within 10 seconds, the rescuers should switch positions and you start compressions again. If the patient requires defibrillation, CPR should be continued while the defibrillator charges as to minimize the interruptions. When the AED arrives at a cardiac arrest incident, it is the only acceptable reason to stop CPR. The defibrillator/AED should be used immediately upon use of electricity or confirmation that electricity will not be used. CPR should be started beginning with chest compressions. I know this is dry material, I know. Well, now we're getting to the meat and potatoes of the ACLS portion. What are shockable rhythms? Remember, I actually did a video on this where I played a beat. So here's how I remember what rhythms to defibrillate. Are you ready? All right, here we go. Defib for V-fib and pulseless V-tach. Don't defib asystole, you won't get them back. Defib for V-fib and pulseless V-tach. Don't defib asystole, you won't get them back. So what are shockable rhythms? Pulseless, right? Defib for V-fib, so we're defibrillating ventricular fibrillation, and defib for V-fib and pulseless V-tach. Don't defib asystole, right? That straight line, beep, that flat line, that doesn't really work. So defibrillation, if you have a biphasic, you're gonna do 120 to 200 up to 360. Monophasic, you're gonna do 360. What are we giving? Drug therapy. We're gonna give epinephrine 1 milligram every 3 to 5 minutes. Amiodarone, they like to test this too. The first time that you give amiodarone for either VTAC, that's pulseless, or VFib, your first dose would be 300, second dose 150, because the max dose is 450, all right? So you add these up and you get 450. Non-shockable rhythms, PEA, which is pulseless electrical activity. That's where it appears on a monitor that these people have a rhythm, but they don't have a pulse. And hence the term pulseless electrical activity, right? And asystole. Asystole is literally that flat line, that beep. Asystole is what you will constantly see defibrillated on the movies. Hey, Hollywood, if you need some kind of medical consultant for your movies to make your movies more realistic, I volunteer. So what are we giving for non-shockable rhythms? We're doing epinephrine 1 milligram every 3 to 5 minutes. Kind of what you saw here, right? So epinephrine 1 milligram every 3 to 5 minutes. Treat reversible causes. I don't think on the exam they ask too much about your H's and T's. It's good to know though if you work on, if you're in the ED or ICU. But H's: hypoxia, hypovolemia, hypothermia, hypokalemia, hyperkalemia, acidosis, right? Are there too many hydrogen ions? And then the T's are tension pneumothorax, toxins, tablets, thrombosis, cardiac tamponade. Return of ROSC, not Ross from Friends. I never really saw that show. Return of spontaneous circulation, or ROSC, not Ross from Friends. Indication of life, return of pulses. So you've done everything right, you've got this patient back, you want to immediately assess pulse and ventilate appropriately. You want to begin fluid bolus of normal saline to obtain a minimum BP of 90 systolic. Approximately fluid resuscitation is 1 to 2 liters of normal saline. Dopamine 2 to 10 micrograms per kilogram per minute for continued hypotension. Epi 0.1 to 0.5 micrograms per kilogram per minute for continued hypotension. Patients who achieve ROSC should be transported to a coronary reperfusion capable facility, cath lab. And this is usually on the test, 90-minute, this is usually on the exam, 90-minute door to balloon time for known post-code STEMI patients. Induced hypothermia, code cool, right? Sometimes they call it code cool. Induced hypothermia or targeted temperature management should be implemented in hospital with a target range of 32 to 36 degrees Celsius for at least 24 hours. Do not begin temperature management if the patient is conscious or answering questions appropriately. Okay, ACLS medical emergencies. Thank you so much for hanging till this point. Okay, bradycardia, first degree, second degree, type 1, type 2, and third degree block, right? For these kinds of rhythms, so if someone has bradycardia, if they have first degree, second degree heart block, type 1, type 2, third degree block, you want to assess the patient. Treatment of symptomatic bradycardia is atropine 0.5 milligrams every 3 to 5 minutes. The max dose is 3 milligrams, okay? If atropine is ineffective, consider transcutaneous pacing. Consider dopamine 2 to 20, consider epi 5 to 10 mics. Okay, so the keyword here is symptomatic bradycardia, okay? If they're asymptomatic, a lot of times we are just monitoring them. For SVT or supraventricular tachycardia, this is above a rhythm that is above the ventricle. First thing we're gonna have them do is vagal maneuvers. Then we do adenosine. Look, I don't know, I have to make, all of this starts to jumble together. So adenosine, 6 milligrams, you're going to wait 1 to 2 minutes. So look, you wait 1 to 2 minutes, 1 to 2, 12 is here. And then if not, conversion, administer If no conversion, I think that should read administer 12 milligrams. So we give 6 first, we wait 1 to 2 minutes, and then 1 to 2 together is 12. I'm not saying 1 plus 2 is 12. I'm saying take this little hyphen away and it's 12. I don't know, just silly things like that help me remember it, right? Or 6 plus 6 is 12. So first we start small. We're giving adenosine 6 milligrams. We wait 1 to 2 minutes. I don't know, 6 plus 6 is 12. You wait 1 to 2, I see the number 12 there. If no conversion, you give 12 milligrams. If SVT persists, seek expert consultation. If unstable, perform synchronized cardioversion. 50 to 100, 200, 300 to 360. So with Brady, we're doing transcutaneous pacing. With SVT, we're doing synchronized cardioversion. For VTAC with a pulse, that's what's different. VTAC with a pulse, we're giving 150 milligrams of amiodarone. Remember, the max of amiodarone was 450. For amiodarone, we're giving administer 150 milligrams of amiodarone over 10 minutes. If unstable, perform synchronized cardioversion. If you do not perform synchronized cardioversion, you could kill them. If the electrical shock lands on the wrong time, boom, you just killed them. AFib, you already have enough to learn for this. This is usually not tested in ACLS, so I'm just gonna go ahead and skip over it. A flutter, it's telling me here, not in ACLS, not in ACLS. The rhythms may be, but not in regards to what are we giving them. Okay, so for a possible STEMI, acute coronary syndrome, you want to obtain a 12-lead EKG. You're going to give it 160 to 325 milligrams of aspirin. You're going to administer nitro. Going to administer nitroglycerin. Caution if right ventricular AMI is present. Caution if known use of sexual enhancement drugs, aka Viagra. They could get extreme hypotension, by the way, because of the vasodilation effect. Administer oxygen, administer morphine in 2 milligram increments for pain relief. Think of your Mona B, okay? Mona B. Morphine, oxygen, nitroglycerin, aspirin, and B for beta blocker now. So usually for ACLS, they may only be testing you on Mona, but in real life now they're doing Mona B, Professor B, right here, Mona B. And then, so you're going to administer morphine in 2 milligram increments for pain relief. Morphine also helps decrease the cardiac demand of the heart, so that's how it helps. And you want to adopt a and this is often tested. The door to balloon time is 90 minutes. Door to balloon time. So by the time that they're going in there, that's what they mean. Stroke. Perform Cincinnati Stroke Scale Assessment. You want to alert the receiving hospital as soon as possible. You want to perform a non-contrast head CT with 25 minutes arrival at ED. And you want to start fibrinolytic therapy if negative for hemorrhage. Obviously, you would never do this if they're having a hemorrhagic stroke. Never, ever, ever. You would make the situation worse. Team dynamics. They may test this at the end. It's kind of like the leftover. Open loop communication is used to ask questions during the resuscitation. Closed loop communication is used to confirm repeat orders. Team leaders are important aspects as they have the ability to address team members immediately if an intervention is incorrect and orchestrate the entire emergency situation and clearly delegate tasks. Tasks should be directed based on scope of practice. Team members who cannot perform a task should make the team leader aware and request an alternate task role. And the medical emergency team or rapid response should be used as a resource if the patient condition is worsening, not just as a means for assistance during cardiac arrest. We see this all the time at the hospital. A patient is declining, we may not know what's going on, and we call rapid response. I love rapid response. Okay. That material was dry, I admit. If you want a copy of this PowerPoint, then just send me confirmation that you subscribe to my channel at nursingwithprofessorb@gmail.com, and I will email you this PowerPoint. All right, sayonara, have a great day. Thank you so much for watching. Make sure that you hit the like button, make sure that you subscribe, and make sure you turn on that notification bell.